So I'm here with my dad, who's a urologist, and he's come to speak to this group several times. And one year in the past, I was able to come down and we were both able to present. So um, we're able to do that again this year, obviously much easier without having to leave the house or the office to be in San Diego in front of all of you. So I am a basic science researcher at UCLA. I'm a professor of molecular cell and developmental biology. And so I study how cells and tissues change in response to different influences. And then my dad is a sexual medicine expert and urologist at Alvarado Hospital in San Diego. So I'm going to start and give a little bit of research, and then you'll hear more of the clinical side. So let me get started here. So I'm going to be talking about some of the basic science research that we do. I'm not sure how much basic science research you all get, but I'll give you just a brief glimpse of some of the things that we do and why we care about prostate cancer. And certainly the goal of basic science is a little bit different than, for example, clinical trials, because we hope that our work, not necessarily, we don't expect it's going to affect the clinical treatment tomorrow, but we hope it affects clinical treatment in the next 5 to 10 years. So we're really working on what can be the next class of treatments or diagnostics that have not yet made it to the clinic. So this is a picture pre-COVID of my group at UCLA, and you can see a bunch of young scientists working to end prostate cancer. We're trying to understand what makes cells change their behavior from normal healthy cells all the way to becoming cancer, and then in cancer, how these cells become resistant to treatment. So that's pre-COVID. So for the last 3 months, our lab was shut down, trying to be as safe as possible. And then just last week, UCLA opened up the research labs again, and we're doing it slightly differently now. So everybody wears masks, and we're all having to be a pretty good distance from each other. So the research is not necessarily going to be as efficient or as productive as it was before, but to be honest, we're just really grateful to be able to get in there and do some more research and try to make important advances. So prostate cancer, when you think of it from a biologist perspective, the way we think about it, we know that in cancer, there's the cancer gets hungry, they have to eat. So cancer cells, they take up lots of nutrients in order to fuel cancer. Of course, they need to grow excessively in order to continue to expand. And cancer cells, they want to spread, metastasize throughout the body, and then ultimately can develop resistance to therapy. And so the very center of all of these activities that cancer cells do in prostate cancer is this molecule called the androgen receptor, or AR. So this is like the central molecule that biologists think about in understanding the disease. So how does this work? Well, the androgen receptor gets activated by a form of androgen called dihydrotestosterone, or DHT. And essentially, this form of androgen, the DHT, once it finds the androgen receptor, they come together and they form this complex. And then that complex can go into the nucleus of the cell, and it can sit on top of the DNA. And it can help find the genes, the parts of the DNA that are important, and can turn on certain genes. And then those genes help the cell do what it wants to do, to grow or to spread. So understanding that this is sort of the central signal and the central pathway that's driving prostate cancer biology, this is where the therapies are predominantly designed against. So androgen ablation or androgen deprivation therapy, it's trying to block the signal from reaching the androgen receptor. And if the signal can't get there, then you don't have any of this pathway. And certainly there's probably many people here who have been or are currently on androgen deprivation, and that's because it is useful to cause tumors to shrink, cause the disease to regress. But the problem is tumor cells can ultimately survive, and over time they can grow back the tumor. So the next line of therapy is commonly inhibitors of the androgen receptor, also sometimes called anti-androgens. And these go to the level of the receptor, blocking this complex from going into the nucleus of the cell, from blocking it from turning on these genes and its ability to grow. And so that's why these anti-androgens, or these AR inhibitors, they cause tumors to shrink as well. But what we're finding in the clinic is that tumor cells, in some cases, can still survive and eventually become aggressive again. So the main pathway is driven by androgen receptor. The main therapies are targeting either testosterone production or the androgen receptor activity. So what are we thinking about? How are we trying to learn something new and important for this disease? So our overall goal, of course, is to improve treatment options for prostate cancer and improve quality of life for prostate cancer patients or survivors like all of you. One of the problems is that some patients remain on androgen deprivation for quite a long time, and that's because the therapy suppresses the growth of cancer cells, but it doesn't completely eliminate or eradicate them. And so we're thinking about, well, could we make androgen deprivation therapy work better? Could we make it such that it doesn't have to be used for such a long period of time? We could shorten that time if we could achieve eradication of the tumor cells. And so the approach that we're taking is to try to study how do prostate cancer cells respond to androgen deprivation therapy? How do they survive that therapy? And maybe by understanding what they do, we can come up with new ways to target that survival response, and could be used in combination with androgen deprivation. So the goal would be you use androgen deprivation to suppress the tumor, and knowing what they do to try to survive, you hit them with a second thing that would try to wipe them out. So that's sort of the overall view of how we're going into this. And what I'm going to do over the next few minutes is take you through how we're modeling that response to therapy of prostate cancer cells to try to better understand the biology. How do they survive this therapy? Secondly, I'll go very briefly into some of the things we're thinking about as possible approaches in the future for therapy. And third, how surprisingly prostate cancer research might be relevant for COVID-19. So to start with the modeling, we can take prostate cancer and we can grow prostate cancer cells in the lab in a dish. So these are just these standard plastic dishes that we use. The cells grow on that plastic. The red that you see, this is the fluid that contains all the nutrients that these cells are going to need in order to grow them. And if you look at what's in one of those plates, here's an image using a microscope to look at the cells. And so you can see, I'm not sure if you can see my mouse here, but if you can, I'm showing sort of individual cells, and then you see also clusters of cells. And so these would be groups of cells that have grown together. And I write AR dependent because these cells are dependent on the androgen receptor for their growth. And so we're studying that process. And next what we do is we introduce an inhibitor of the androgen receptor. This one is called enzalutamide. It's a commonly used anti-androgen. It's called Xtandi in the clinic. And what you can observe if you look at the weeks of treatment and you look at the cell growth rate. So initially they have a very good cell growth rate. And then after just a few days, it starts to plummet. And that's because these cells are indeed dependent on the androgen receptor. And so when you block it, the cells stop growing. They don't completely stop growing, but they go really slowly. But then something interesting happens, which is about 4 weeks, they start to turn up again. And then by 5 or 6 weeks, they've almost reached a new plateau, which means that they've reached a growth rate where they're sort of happy with. And so something significant has happened where initially they're very unhappy, but then they figure out a way to become tolerant. And so this is sort of the step that we're interested in understanding. How do these cells tolerate this drug, and how might we try to eventually wipe them out in that stage? So the first thing we did is look at these cells. So again, more than a month of treatment in this androgen receptor inhibitor or anti-androgen called enzalutamide. And these cells are ultimately enzalutamide tolerant is the term that we wanted to use. And so when we look at them, they look quite different than I first showed you over here. And if we zoom in, you can see something that actually resembles a group of neurons in the brain almost, where you have this cell body and then these neurite-like projections coming off that you didn't see prior to treatment. We could actually measure that, so we can quantify the length of these neurite-like projections. On the left, each green little dot here is a different projection from a cell. And you can see in our control setting, cells that are just grown normally. And then when you treat them with this anti-androgen and let them come back after about a month, they're in this tolerant stage, you can see there's a significant jump up. So they have many more or much longer of these neurite-like projections. So the cells physically look different. But then we wanted to know, more than just how do they look, what's actually happening inside the cell? And there's this incredible technology we can use, enabling us to measure 30,000 genes at a time in cells from different stages. So we could look at the cells before treatment and then look at this tolerant stage where the cells are allowed to be able to continue growing in the presence of the androgen receptor inhibitor, and look at what's happening to many, many genes at a time. And so we can look at individual genes, but we can also look at larger patterns of genes. And so in this model where we're growing prostate cancer cells in the lab, we're treating them with this anti-androgen and allowing them to reach this tolerance stage, we looked at the larger patterns, what's changing. And one of the things that we found, one of the pathways that we would say comes up is axonal guidance. This is something associated with, we think of neurons in more like in the brain than in the prostate. And then when we look at individual genes, some of the genes that get turned on by androgen or the androgen receptor, they all go down. And genes that normally are only turned on in neurons, they go up. So something very clear is happening, not just in the way the cell looks from the outside, but also what's happening on the inside. But we were worried, is this just something very strange that happens when you grow cells in a dish in the lab? Because that's not the normal environment. And so we were able to make use of a really nice study where they followed men with locally advanced or metastatic prostate cancer, treated them with androgen deprivation, and they took samples before and after treatment. And they could do the same thing, look at 30,000 genes at a time in tumors before and after treatment to understand what changed. And again, when they looked at the larger changes that happened, sort of zooming out and looking at what's generally happening, again, they saw things like axon guidance going way up, terms that shouldn't be associated with prostate or prostate cancer cells. And then looking at individual genes, again, genes that get turned on by androgen receptor, they went down. And genes that normally are found in neurons, they went up. So to summarize what's happening, when we treat prostate cancer cells in a dish with drugs that block the androgen signaling pathway or these anti-androgens, the cells gain neuron-like features. They look sort of like neurons and they turn on neuron-like genes. And actually similar features are observed when clinical tumors are treated with androgen deprivation therapy. And so the good news is that means our model that we're using in our lab reflects some features of clinical treatment. And so this very sort of cheap, easy to study model in our lab might be helpful in teaching us something about what's happening in the clinic. And so what we wanted to ask is, could we use this model to then find some new things that we don't know about prostate cancer and maybe inform potential combinatorial treatments where we could use the drugs that block androgen or androgen signaling and also something else so that the cells, instead of just getting suppressed, we completely eradicate them. So that's the first part. That's a relatively new approach in our lab, modeling prostate cancer in a dish to try to look at some new things. In this next section, I'll give you just a very brief hint at what we're thinking about doing next in the lab. in terms of combinatorial therapy. And again, just to remember that what we're thinking about is a little bit further down the road, trying to understand what's going to be the next wave of treatments. So we start with this hypothesis that you're taking tumors or tumor cells, you're treating them with this drug. Like I showed you, their growth rate goes down, but then eventually it comes back. So cells are adapting to the new surroundings, the new conditions. And so what we imagine is that as cells adapt, their energetic demands change, meaning the things they need to survive are going to change. The fuel that they use, the food that they eat, the things that they really need. And so if we can understand that, maybe we could actually figure out how to starve the tumor cells. So if we know what they need to survive, then we can take that away. So as we think about, well, what do cells need to grow? One of the things we hear about is protein. And what protein really means is you have amino acids. And there's actually 20 amino acids. Some of them are essential amino acids. This means things that our bodies or our cells don't make on their own. And these are things we have to take up from our diet, from food, in order to fuel the body and get the cells what they need. And then we also have things called non-essential amino acids. These are things that our body cells can make, and therefore we don't need to get them from the diet. So we thought it'd be kind of an interesting experiment to take away individual amino acids one at a time from prostate cancer cells and ask, what do they really need to survive? What makes them unique? And might that change in response to treatment? So here's an experiment that we did. Essentially on the left axis, what we're plotting is how many cancer cells there are. We grew cancer cells, in this case, just for 3 days under different conditions. So this black bar here, this is your normal complete condition. So this is how cancer cells should grow without treatment. And as we extend the line out to the right, anything that falls along that dotted line, really they grew just like normal. And then this next bar, sort of the gray, the dark gray, we took away all 20 amino acids. And you can see that they grow about half as well. So amino acids are certainly important. And then anything that's down here near this level, those amino acids were important for their growth. So in the gray, the light gray, these are all the essential amino acids. So we took out one at a time, and you can see they truly are essential. And then in the blue, these are the non-essential amino acids. These are the things that cells can make themselves. And so when you take them away, it's generally okay because the cell can just make more. So, and I'll highlight one of these called serine, SER. This is one of these non-essential amino acids. Again, it's not required because cells can make it themselves. As we began to look at what's happening to the cancer cells when they get treated and when they reach this tolerant stage where they can survive even though we've blocked the androgen receptor, there's something interesting that jumped out at us. So I'm showing you a biochemical pathway where it's part of the pathway of how cells make serine. So each of these arrows is actually a different biochemical step in the process of making this amino acid called serine. And the black letters indicate these precursors to make serine, and then the blue represents the enzymes, which is the key catalyst that carries out this activity. And so when we measured these 3 enzymes, how much of the enzyme is actually there? What we found is that these 3 enzymes that are really key to make serine, they all go down when you treat cells with the anti-androgens, and then the cells reach this tolerant stage. So there's less of the enzymes to be able to make serine. Now, we actually measured how much serine was inside of the cell in the normal stage or after treatment and they reach this tolerant stage. So actually, they had about equivalent amounts of serine. But when we looked at how much of the serine was actually made inside the cell, there was a giant difference. And most of you don't normally look at biology plots like this all day, but I do. And these are major differences. It's very rare to see such a difference. And so in the green, we're just plotting how much of the serine was made inside the cell. And what you see is from the normal condition to this tolerant stage where the cells are grown with the anti-androgen, it's a dramatic decrease. So they're really not making a lot of serine inside the cell anymore. So to summarize, normally prostate cancer cells, they don't need serine from the outside because they can figure out how to make it themselves. But what happens is when we treat them with the antiandrogens, the enzymes that make serine go down, and actually we can show that they're making less serine. And so what we think, as we kind of go back to the general approach I introduced, which is, could we make androgen deprivation therapy work better? Could we do it so that we could achieve full eradication of tumor cells, not just suppression, and prevent the regrowth of tumor cells later? And we wanted to study, how do prostate cancer cells respond to and survive androgen deprivation, and look for opportunities to possibly hit with a second therapy. And so now we're starting to think about, maybe we could starve tumor cells of serine, and that might be an effective approach to cooperate with androgen deprivation. If the cells are having trouble making it themselves after blocking androgen, then perhaps we could mix a dietary therapy to block this one amino acid with a standard therapy of androgen deprivation and prevent disease recurrence. And that's something that we're really excited about pursuing in the lab over the next few months. So now I will touch on sort of a surprising aspect of how prostate cancer research could be useful against COVID-19. So data coming out of China initially showed that the majority of patients with COVID were actually male. Being male is an independent risk factor for disease and death from COVID. And then in Italy, this was repeatable. So men were the majority of COVID patients as well as COVID deaths. So people started to think, is there a role for androgen or estrogen in disease risk? And then a really important study came out of Italy where they looked at more than 4,000 patients with prostate cancer, some of which were on androgen deprivation and some of which were not. And the men who were on androgen deprivation were actually 4 times less likely to get COVID and 5 times less likely to die from COVID. So it's not just that males have a higher risk, actually males on androgen deprivation have a lower risk than males not on androgen deprivation. And so, well, how might that work? The most obvious or most likely hypothesis is that the androgen receptor helps to activate receptors on the surface of our cells that allow the virus to get in. So this pink circle here, this is SARS-CoV-2. This is the virus that causes COVID-19. It can't just get into our cells on its own. It actually needs help. And some of our cells have these 2 molecules. One's called ACE2, the other is called TMPRSS2, TMP or SS2. And ACE2 and TMPRSS2 help the virus get into the cells. And so if you have more ACE2 and more TMPRSS2, it's easier for the virus to get in. If you have less, it's harder for the virus to get in. And so people started to ask whether androgen is maybe turning on ACE2 and TMPRSS2, making the virus easier to get in. And there's some data now emerging that this is true in the lung. And so we did an experiment for ourselves where we took mice, treated them for a week with drugs that block androgen signaling. And then we looked at these factors that allow the virus to enter our cells, not in the lung, but in the nose, because actually when we breathe in these respiratory particles, infection in the nose is probably one of the earliest places it gets into our body and how it could ultimately replicate. And so we measured the level of this receptor for the virus called TMPRSS2. And when we treated these mice with the anti-androgen enzalutamide, same one I actually was showing before in the cells, when we treat them with a different anti-androgen called bicalutamide for a week, or if we do a short term with enzalutamide, and then we measure how much of this TMPRSS2 is in the cells of the nose, we actually saw it went down dramatically, and we repeated that, showed the same trend. And so, to summarize, there's an increased risk of COVID for males. However, androgen deprivation seems to reduce that risk. And there's some evidence coming out of other labs and then some evidence from our lab that blocking androgen signaling might actually lower levels of these receptors for the virus. In other labs, they've shown it in the lungs, and we're showing it now in the cells of the nose. And right now, there is a clinical trial going on at the West Los Angeles Veteran Administration, as well as at other VAs around the country, to treat COVID male patients with these anti-androgens and to see if this might be reducing disease load or helping these patients. But what they're also going to do is take nasal swabs, and we're hoping to see whether what we found in the mice is true in people, that maybe the levels of this receptor could be reduced in the nose treating with anti-androgens. So to summarize, it was really nice to be here to present some of the basic science research. I know it's sort of not the type of thing that most people think about every day, but it's what we think about. I want to thank the members of my lab who performed the experiments and are working very hard. They're very excited now to get back to research and try to make good advances. Very grateful for getting support to do research from sources like the Prostate Cancer Foundation, the Department of Defense, American Cancer Society, the National Cancer Institute. And of course, we're really grateful for patients, surgeons, pathologists who help us get access to fresh human tissue to study prostate cancer in the lab. And that is the conclusion of my segment. So how long would you suspect it would be needed to be on ADT for some of these effects? So in our experiments, we're modeling a very short period of time so that we can do this in a reproducible manner. The clinical data that looked sort of similar, in the clinical data that I showed, they had treated for 22 weeks. I think these are all kinds of things that would have to be determined empirically, but there's a few steps in between, where we are now and reaching the clinic. And so understanding how long does it take on androgen deprivation to, for example, change the behavior of the cell so that it needs to eat more of one amino acid versus another. These are kinds of things we'll have to determine, but we're very excited to move in that direction. All right, I see a second question. Is this seen with any other markers involved in prostate biology in cancer, such as PSA or just androgens? So, so certainly we see PSA change pretty dramatically in response to anti-androgens. Whether PSA could be used as an indicator of kind of the state of the cell and what nutrients it would want to be eating most, that's something we don't know yet, but that's something we could look into. Another question, what foods are rich in serine? That's a good question. You'd have to probably work with a nutritionist. There's an idea right now there's a lot of really effective cancer therapies that are not fully effective on their own. And so this idea of mixing a dietary therapy with a sort of standard pharmaceutical inhibitor is gaining traction. And of course, the best case scenario would be to have a pretty normal diet without having to do, without having to make a lot of changes. Right now, they're kind of thinking about like protein shakes with, let's say, 19 amino acids without the one that could be fueling the cancer. So I think there's going to have to be some advancement in the area of nutrition and dietary therapies that really target individual nutrients, individual amino acids. I think it would be difficult to ask someone to take a protein shake as their main meal replacement for an extended period of time for cancer therapy. On the other hand, anything that could work, I think people would be open to, depending on your circumstance. So those are interesting questions. How long would you expect it would be to bring this to reality and usage? So that's an important question. Typically it takes, unfortunately, like 5 to 10 years for certain lab-based observations to make it into the clinic. But often that's talking about when you're developing a new class of therapies. I think in terms of when you're talking about nutrition or dietary therapies, I'm certainly hopeful that it would be a lot faster because you wouldn't need to do the same kinds of toxicity studies and understanding how drugs work would be different than nutrition. So hopefully this is something that we can do over the next few years, and if it's promising, we could advance to the clinic quickly. How do you pick patients for your research? Post-radical rotate surgery, incidence of recurrence and rising PSA. So we don't do human subjects research in my lab. We are modeling prostate cancer. And so when we need fresh cells, we are able to get them from UCLA in what's called the de-identified manner, which means the tissue that goes to us, we have no idea who it came from, and that's important to protect the patient. So that's the way we do it in order to be as ethical and fair as possible. But certainly, if this kind of research would lead to a therapy, then we'd want to figure out who's most likely to benefit from it, and we would want to use those clinical parameters. And so would PSA level be a good indicator, or other potential factors? That's something that would be important. And then will treatment with Lupron have similar results with COVID as enzalutamide? That is what people are, I think the clinical trial is using Tigarelix, which is, I think, similar to Lupron. So I do believe that treatment with Lupron may provide some protection against COVID, but that hasn't been published yet. So, but I think that's very possible. Great. So I really appreciate all the questions, and again, really enjoyed getting to speak. And now I'm going to pass things over to Irwin Goldstein.
So again, Andrew, you're fabulous. Thank you. To the Informed Prostate Cancer Support Group, I thank you. This is like the opening slide. This is my beautiful hospital. I put my email address down here. I'm very happy if people have questions and want to email me directly. Please do so. Andrew sort of focused on the aspect of prostate cancer that we all rely on, which is the future research. I'm going to deal with the sexual health concerns of patients. So again, to speak with my son on a Father's Day weekend is very, very special. To Lyle, Jean, and John, thank you. And to those members who are patients of mine, thank you for being here and listening. I have a similar sort of slide like Andrew of try to dividing this talk into various sections, and those are the sections that I wish to divide. I'm very happy to share my slides or PDFs of the articles that I'm going to do. If anyone wants anything, just shout out to my email address and I will get that. So the World Health Organization says that in general you have a right to any health, but specifically they called out the sexual health and saying that you have the right to freedom from fear, shame, guilt, false beliefs, and other factors inhibiting your sexual response and impairing your relationship. So we take that to a high level, and we have put together a facility here in San Diego that focuses on the rights to sexual health. So you can have emergency room providers and family medicine providers and so on and so forth. But we are providers of sexual medicine. There's not that many of us, but we are those individuals who embrace the study, diagnosis, and treatment of men and women with sexual health problems. And that's what we do. So we apply the basic principles of scientific evidence-based medicine to men and women with sexual health problems, and we do the biopsychosocial. We have a facility that has 3 experts in it. We have 3 pelvic floor physical therapists, myself, 2 nurse practitioners do the physiologic, and we have a amazingly trained from the Kinsey Institute sex therapist that does all the psychosocial, interpersonal, and psychologic concerns. So the take home from the introduction is that there are specialists who focus on male and female sexual dysfunction. I'm going to start with the erectile dysfunction material. So for those who don't like looking at pictures of human beings and sexuality, you may want to close your eyes for some of these things. But for those who don't mind it, these are the labia of a woman, and this is heterosexual sex. This is the urethra of a woman, that's her G-spot. This is the inside of the vagina. That's the G-spot here inside of the vagina, and more of the same. And to achieve heterosexual intercourse, the erect penis has to go inside the vagina. So it has to push apart all the various layers of the vagina. So it has to do work. That means the penis has to have what we call sufficient axial rigidity to prevent buckling while penetrating the vagina. That's the so-called engineering definition. And this would be something that has the ability to bear the load or the resistance to get into the vagina. And this resistance within the, or pressure within the penis is sort of inadequate, and then it buckles. And we can actually measure in an erect penis how much force it requires until buckling occurs. So these are some of the mechanical things that we deal with. And it turns out that the average vagina poses the resistance of about 1 kilogram, 2.2 pounds, for the erect penis to achieve penetration. So just to go with some physiology, these are the two corpora cavernosa. We'll just call them the erection chambers. This is the corpus spongiosum. That's what you ejaculate or urinate through. And there are a few constituents to the erection chamber. There's an artery, there's a tissue, there's a space here, and then there's an envelope around the whole thing. So those are the 4 constituents, all important. Here's constituent 1 on a sort of a blow-up view. That's the pressure coming in. So 120 over 80 millimeters of mercury, you have an average of 100. Here's the erection tissue. Here's the space, so the blood diffuses through the tissue. There are veins within the space. So there are veins that originate and suck blood from the peripheral edge of the erection tissue, and they exist basically in there. And then they pass through the envelope, passing into veins that go back to the heart. So in the flaccid state, there is a situation of blood in and blood out. However, in the erect state, in the normal situation, when the muscle relaxes during sexual stimulation, the tissue expands outwards, and that space that's over here gets shut down. So there's actually a pressure against these veins, so nothing can now escape. You can see the lumen of the vein here allows blood out, but the lumen here is compressed. It won't allow blood out. So blood coming in can't escape, and the penis maintains its pressure until there's basically an ejaculation. The ability for the tissue to expand, its so-called expandability, is defined visually by the thickness of the spring here. Very thin spring means it's easily able to expand. So after introduction of the nerve-sparing technique by a surgeon in Baltimore, there was a lot of hope that a radical prostatectomy would not result in injury to the neurovascular bundle, but there would be preservation. And other surgeons beyond the Hopkins doctor thought that their results were excellent. But however, reality set in, and the figures of potency in daily practice are way, way different. And we never reached the preoperative status, despite meticulous bilateral nerve-sparing radical prostatectomy, even with or without the Viagra kind of pills. So a large publication of an international multi-center trial put together data, and it finally revealed the truth, and it put into perspective the data that the reality is about maybe a quarter of patients are able to preserve erections. It's really sad. 3 out of 4 cannot. It's probably even high, a quarter. In my experience, it's high. And if you use different metrics that are not so strict, you can sort of eke out a third of patients have potency. But in general, despite the word by your friendly urologist that it's possible, the reality is it's not that possible. So what's the reason? Well, the reason for the disappointing techniques is that despite meticulous nerve-sparing techniques, something happens to the nerves around the prostate, and that results, whether it's impossible to prevent because you're just operating, or there's thermal energy, or whatever the reason is. Neuropraxia means nerve injury, and the nerve injury then results in downstream changes to the tissue. So let's just go over, we talked about in the normal situation, here's the tissue, here's the nice expandability with the very thin spring. And now we're going to introduce scarring that happens as a result of nerve injury leading to death of the smooth muscle cell. That's called apoptosis. And a smooth muscle cell that dies turns into what's called a fibrocyte. Collections of fibrocyte are scar. And if you look here, you can see that the expandability of the tissue turns to be more difficult because scar tissue won't expand. And the inability to expand allows those little veins in these regions to continue their escape of blood. And it's like trying to have sex using a tire that has a nail in it. You just can't hold the pressure. So this is one of the diagnostic and subsequent treatment strategies where you can hyper relax the muscles of the penis by injecting drugs. They're Viagra-like drugs. They essentially are drugs that cause muscle relaxation. We use the acronym words of Biomex and Trimex to describe them. But at the end of the day, in an office setting, I could have patients have an erection with these agents, and I take the ultrasound probe and we place it in 3 different parts of the erect penis, and we use specific settings on the machine so that everybody gets the same study all the time. This way I can compare in a longitudinal way what's going on. And this is a picture of an ultrasound. You can see it's perfectly gray in a normal person. It's called homogeneous. Blood goes into every nook and cranny of the penis, and blood is represented by gray, and gray is seen everywhere. So that's one erection chamber. The other erection chamber down here is the urinary chamber. This is a biopsy of healthy tissue showing the majority of the tissue is this red material, and red is what is muscle. So if muscle is to die, the hypothesis of nerve injury as a result of prostatectomy, then we'll see more blue. You'll see there is the control blue here, but you can see more blue when the tissue is scarred. So the difference here is the death of these myocytes turning into fibrocytes. You see collections of blue. Now the difference is blood can't go where there are collections of blue. So on the ultrasound, instead of seeing everything gray, we get to see tissue where there are essentially what we call Swiss cheese effect, or black holes, representing regions where blood can't go. And these would be regions of erection tissue scarring. And these are just different studies of ultrasounds. And pretty much everyone I've ever studied in a prostate cancer situation has shown this, what we call non-homogeneous hypoechoic, less echoes. These are regions with less echoes, and these are regions with normal echoes. All right. In someone with ED, in particular, the radical prostate patient, we would do our thing at San Diego Sexual Medicine. We have a sex therapist. We do pelvic floor physical therapy. We have the erection hardness scale. We assess the penis in its flaccid state. We do hormones. We do nerve testing. And then in the pharmacologic erection state, we do all of these things to find out about the tissues. And then once we get this information, we can get to symptomatic treatments or disease modification treatments. Most people know about pills and vacuum devices. A new mechanical constriction device that we particularly like and prescribe it a lot, it's called Giddy, G-I-D-D-Y. It's C-shaped, and the elastic band goes around the phalanges of the C. So it sort of goes around the penis. It has phalanges here, and the elastic band goes around. It's a pretty cool device. And penile self-injection is a big workhorse therapy for us in our practice. We, of course, do penile prosthesis if needed. And then disease modification, if there's sex therapy, couples, counseling things, we do that. Physical therapy if we need that. Endocrine therapy if we need hormones. We have a fabulous neurologic strategy, and I'll get to that. We do strategies to increase blood flow, and their yellow things are things that I'm going to spend 2 seconds on, and that's regenerative treatment. So a brand new article just came out, and if anyone is interested in this article, it's 30 pages. It's a fabulous, fabulous article. It's a German investigator. It's a fabulous colleague of mine, and he has low intensity extracorporeal shockwave devices in his practice, and he has been treating patients who have radical prostatectomy. So I'm going to show you his data. So in the history of extracorporeal shockwave therapy, for anyone who knows, in the 80s, the device came out for breaking kidney stones. So it pulverizes stones into powder. Therefore, you don't need to provide them surgery, the patients who have the stone. And not my son Andrew, but my son Brian has a series of kidney stones, actually. In orthopedics, low intensity shockwave therapy has been used. In cardiology, it's been used. If you have a heart attack, you'll get shockwave therapy to prevent scarring of the heart. And we're using it since 2010 in men who have erectile dysfunction. This is a device that we have in our office. It's a device that Dr. Porst speaks of a lot in his article. This is actually made in Germany, and it's genuine shockwave therapy. I use the word genuine shockwave therapy. One of the horrible parts of the United States of America is the scamming opportunities of dishonest people. So there are dishonest providers that say they're providing shockwave therapy. The typical product is called Gainswave. It is not a shockwave device. It does not provide shockwave energy. It espouses benefits that are based on shockwave data. And I don't want to get too emotional about this, but Gainswave is not real shockwave. Now, in his article, these are the various energies that the device can use. We typically use an energy of 13, and these are the parameters that we use for men. And I was going to say, straight out of his article, and again, if you want the article, very happy to give it to you. In summary, immunohistochemistry or immunofluorescence studies show that low intensity shockwave therapy resulted in an increase in smooth muscle, which is what you're trying to do. An increase in elastin fibers gives it more stretch, down regulation of the things that cause scarring. Oh my gosh. Tissue growth factor signaling pathways are changed as a result of this. And in light of the findings, LIESWT, low intensity shockwave therapy, may be an appropriate method to delay structural changes in an aging penis or in a penis post-radical prostatectomy. And I just want to show you, because we've done a whole bunch of these over the year we have the device. This is a person pre-radical or post-radical prostatectomy who came to us with ED, and you can see the Swiss cheese effect in the tissue. And subsequent to our treatment, we can now repeat the study. Exact same settings on the machine, exact same locations. You can see greater homogeneity and improved erectile function. So there's no question in my mind this, in some patients, is very successful. And it's based on a lot of basic science work. So Andrew showed you basic science work with prostate cancer. This is basic science work with erectile dysfunction. In 2016 in San Francisco, a colleague of mine took some rat penises. You can see the device providing energy to the rat penis that's erect here. And it did so in two different groups, a low energy group and a high energy group. And the essential findings were that shockwave therapy resulted in exactly what we want it to be: increased blood flow, tissue restoration, nerve regeneration, reinnervation of the tissue with the nice nerves that release what's called nitric oxide. And the positive effects we're seeing more with the higher energy waves. So as a result of everything going on in the research with LIESWT, we've changed our strategy. We offer patients a PD-5 inhibitor, and we try to do shockwave therapy soon thereafter their surgery. And we have some data to show that it has helped people. But I have to say, the genuine nerve-sparing prostatectomy with all its hope has not worked. So if anyone is interested, we are doing the first ever in the United States sham-controlled randomized prospective study to examine the effects of shockwave therapy in humans. So if you want to join our trial, email me or somehow get a hold of me. These are the inclusion criteria. You have to be a certain age. You have to be in a relationship heterosexually for at least X number of months. It has to be heterosexual because the outcome measures we use to assess efficacy are based on heterosexuality. It's a little unfair to homosexual patients, and I apologize, but it is what it is based on the outcome measure. You have to be a certain size, you have to have ED, you have to have a certain testosterone value. You can't have a higher PSA than 4. You have to wish to be sexually active, and you have to be willing to stop any and all other things so that we can study what the effect of shockwave is on the erectile function. These are the exclusion criteria, and we're going to switch out of it. We're very excited by the advance that shockwave therapy has added. Now, for urinary incontinence, let's just say again, the hope that radical prostatectomy, nerve sparing, would prevent incontinence has also not been all that successful. And there's a whole bunch of people who have radical prostatectomies of urinary incontinence. So we got a hold of this amazing device. It's an electromagnetic chair. You wear your clothes. We found that you can't wear a lot of pads when you're doing this because the energy won't get to your perineum. But the FDA has cleared this for the treatment of urinary incontinence in boys and girls. And basically, if you sit on the chair, you get about 11,000 Kegels. I'll say that again, 11,000 Kegels in the 28-minute session. And it activates the muscles of the perineum. This is a person doing a Kegel, and this is the Kegel on the machine, so it's far more effective and innovative. And basically but this is a problem. The pelvic floor sags. This is the treatment, and now the pelvic muscles are strong. So you just sit there. There's nothing. You use your computer and you go on your emails while you're doing all this. So this is a report of it's called HIFIM. HIFIM is high intensity focused electromagnetic procedure. By the way, if you don't know, I'm a biomedical engineer from Brown University, so I love devices, bioengineering devices. So the shockwave and the HIFIM machine to me are just fabulous stuff. So post-prostatectomy incontinence, PPI, is common and bothersome, much more common than the providers who do the surgery will let on. This is a pilot study in just a few patients and the outcome measure is called the King's Health Questionnaire, and I'll go over what that is. The King's Health Questionnaire decreased significantly. A lower King's Health score is meaning positive information in terms of all the domains. There's an incontinence impact, social limitations thing, sleep energy. I'll show you all this stuff. So these are the data of the King's Health Questionnaire. The blue is what you were before, and the post-treatment is the benefits that Emsella, the chair, does. So basically, it really impacts positively on incontinence. And when you impact positively on incontinence, it affects you in many other ways, basically is what it's saying. And we hope to do more and more research. So guess what? We're doing another clinical research study that anyone who's listening can participate in. The primary objective of this study is to prospectively document the safety and efficacy of the BTL Emsella in either what's called stress urinary incontinence or urge urinary incontinence or mixed stress and urge urinary incontinence. And we're going to record a bunch of things, and we're going to use, instead of the King's questionnaire, we're using the QUID questionnaire for urinary incontinence diagnosis. Here are the inclusion criteria: a certain age, a certain size, that you have the problem, that you're sexually active and wish to be sexually active, you're willing to continue beyond the exercise to your pelvic floor muscles to other exercises. And here are the exclusion criteria. Now we're going to get into Peyronie's disease. So this is common after radical prostatectomy. Not exactly sure why, but it really is common. The penis it gets shorter and has a different shape. So if this is pre-radical prostatectomy, it's not uncommon to have a curved penis at the end of the procedure. These are just various curved penises. They go in all different directions. And here are some pictures from my office. And these are negative to people: low self-esteem, poor self-image, performance anxiety, loss of sexual confidence. And just to remind people that the FDA has approved a treatment that if you inject it into the scar that develops, that makes the curvature, can cause the curvature to be less and actually the length to be increased. So this would be after the treatment, the penis would be more straight. And here we use a machine called a goniometer, which allows us to measure the change in angle. And this person was something like 70 or 80 degrees, something like that. And now the person's 20 degrees with these injections. I'm going to spend time on testosterone, and I know testosterone is going to confuse everybody because my son brought up testosterone therapy, and then testosterone, anti-testosterone therapy or testosterone deprivation therapy, or what's called hormone deprivation therapy, as to help men with prostate cancer. And then he brought up that you can do the deprivation therapy to people with COVID who will survive. So I'm going to totally confuse you here. I'm going to tell you that in selected prostate cancer survivors, I'll say that word very carefully, selected prostate cancer survivors who don't have the risk of prostate cancer. There are plenty of people who have this surgery, despite the incontinence and erectile dysfunction issues, don't have the PSA values anymore. They're considered survivors. And testosterone therapy for them is a magical therapy that is strongly encouraged. So I'm going to say I'm an editor-in-chief of this journal, and this is an article that came out in it, and that's when it was published. And if anyone wants this article, as any other articles people want or slides people want, you can email me, and I'll be honored to give it to you. So testosterone therapy has historically been considered sort of evil. But it's not really true. Everybody thought testosterone was the fuel for the hungry prostate to grow, and it's actually not that true at all. So we looked at the literature, or at least this group looked at the literature, and we found that testosterone therapy really helps the symptoms of those who have surviving prostate cancer but have low testosterone states. And they don't have the perfect life quality, but testosterone therapy in these selected prostate cancer patients whose PSAs are virtually not there anymore, we can improve their life quality. So conclusion is, despite the reluctance to use testosterone therapy, evidence suggests it's really safe and effective and life-changing in people with non-high risk prostate cancer. So that's what we're going to focus on here. These are the data. There's tons of it in the article if you want to read it. These are men who presented who had prostate cancer but had low testosterone. And you'll see, and hopefully Andrew can help us and he can understand and explain it to us. If you present with prostate cancer with low testosterone, and you want to read these articles, you see there is a higher frequency of bad things. So people who have low testosterone tend to have worse levels of grades and stages of prostate cancer. But if you look at people who presented with prostate cancer, but their testosterone values were normal or high, which again is what we're trying to achieve with treatment, they had much less risk of prostate cancer. Their diseases were far less aggressive, and giving them the treatment did not result in any risk of making them have prostate cancer. So this group, and I want to spend time on this, would recommend consideration of testosterone therapy in those men who have hypogonadism, had a history of prostate cancer. For them, we believe that the therapy has benefits that outweigh the risks and can change people's lives. So here's some stuff that hopefully will help you, convince you. Now, Andrew talked about androgen deprivation therapy. I want to show you what androgen deprivation therapy actually does to the human being. It causes metabolic syndrome, abdominal obesity. It raises the triglycerides. It lowers LDL. It raises cholesterol. It elevates the bad cholesterol. It raises your blood pressure. It gives you diabetes. It causes you erection problems. It makes you difficult to pee. It makes your bones weak. It causes you lots of mood changes and cognitive changes. And it makes you have heart attacks and strokes by affecting the lining. That's what androgen deprivation does to people on it for a long period of time. So androgen deprivation therapy is black, the control is here, and this is metabolic syndrome, which is the diabetes, hypertension, high cholesterol group. Abdominal obesity is higher in androgen deprivation, high glucose, insulin resistance. These are all complications of androgen deprivation. Triglycerides go up, cholesterol goes up, blood pressure medications go up, hemoglobin A1C goes up. That's the diabetes slide. Hemoglobin A1C goes up. So androgen deprivation, let's argue, is not a perfect thing for a male's life quality. And what's the difference between acute testosterone androgen or deprivation therapy? So this is the treatment for prostate cancer, and then just aging, slow developing aging, chronic illness, deficiency of testosterone. And I'm going to tell you, I don't think there's any. You just slowly get diabetes, you slowly get bone disease and all that sort of stuff. Here are the treatments that you have seen or heard of. These are the gels, the injections, the patches, the pellets, the classic things. I'm going to share with you, there's a brand new treatment, it was very exciting. The traditional gels are 1 day use. They go up and down in a day. The injections go up and down in a week, and the pellets last about 4 months. Here is the injections. Here's where we inject them. The muscle is called the vastus lateralis. We train people how to do this. It's really simple. You do it once a week. You give the correct amount of medicine. You follow the blood levels. Here's the pellets. Now, I'm going to excite you. I'm very excited, and pretty much most of my patients starting testosterone therapy are going on the oral formulation. Finally, an oral pill. You take it twice a day. The bad thoughts about oral testosterone pills was that it hurt the liver. So newer companies, there's 4 of them now, this is the first one out to market, actually put the pill in a thing called a lipoprotein, and that forces it to go in what's called the lymphatic system. So it doesn't enter the liver, it enters what's called the lymphatic system. Then the lymphatic system dumps it into the venous system and around your neck, and that place is called the thoracic duct. The name of the new medicine is Jatenzo. It just got approved a few months ago. You start at 237 milligrams twice a day. The other advantage of twice a day drugs is your blood level goes up and down twice a day. That's the physiologic way blood levels of testosterone are. When you give injections, when you give patches or whatever, the blood levels are flat, which isn't the physiologic way. And we have beginning data to show that the testicle size and the fertility problems will be lessened with oral pills. Anyways, you start at 237 and then you measure your blood level. If it's correct, you stay there. If it's too much, you titrate down. If it's too low, you titrate up. Pretty straightforward. Does testosterone improve bone health? Yes, yes, yes. This is testosterone versus placebo. Does testosterone allow you to pee better? Yes. The metric for recording pee, which is International Prostate Score, goes down. Does testosterone improve blood pressure? Yes, it lowers your blood pressure. Does testosterone lower your blood pressure? Systolic, this is now diastolic. Does it lower your waist circumference? Does it get rid of fat? Yes, 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 it gets rid of fat. It turns fat into muscle, which is what you really want. Does it lower fat mass? Yes, all of these measures of fat mass are lowered when you take testosterone. Does it lower cholesterol? Yes, these are all the things that it does, from cholesterol and glucose, all the positive things. This is HDL cholesterol is improved, blood sugar. You actually make people who have diabetes with lifestyle alone, you add testosterone to the lifestyle, you now make them have hemoglobin A1C, not even considered diabetic. So if you're treating with testosterone, of course, there are risks. Testosterone in some people, not everybody, because it normally lowers blood pressure, but in some people can increase blood pressure and therefore increase the risk of bad things. So you have to, of course, if you're going to provide treatment to people, you have to follow their overall health, including their blood pressure. The changes in blood pressure are not that much, 2.8 milligrams, at least using Jatenzo. That's not much of an increase, but for some people that can be much. These are people with higher blood pressure. You get almost 5 millimeters of mercury higher, etc. Okay, so does it change PSA? It actually doesn't change PSA. It doesn't change it any different than topical testosterone, the oral pill, and it really doesn't change PSA in the vast majority of patients. And other things that are associated with testosterone treatment are here, and you got to follow these patients basically. All right, I'm going to spend 2 minutes on other forms of sexual dysfunctions. There are people who can't feel their penis. There are people who have no pleasure when they're having sex. They don't get a pleasurable orgasm. We call that pleasure dissociative orgasmic dysfunction. There are people who have orgasm and they can't have orgasm. It's muted or delayed. So these are hypofunctioning cases. If we're looking at their brains, when you touch the penis, it would light up here. And if you touch the penis, it won't light up here because the information is not getting to the brain. Then there's the opposite. I'm not going to spend too much time on the opposite, but there are people who have horrible pains in their penis, dysesthesias or horrible pains. when the nerve is hyperfunctioning as opposed to hypofunctioning. So in hypofunctioning, my job is to find out where the nerve blockage is in those people who have poor orgasms, can't feel, no pleasure, that kind of thing, or the opposite, have too much pain in their penis. And I recognize there are 5 places where neurologic injuries can occur that would either cause no signal or too much signal. And if the problem ends up being in the spinal cord, which is a common region, the spinal cord, the bottom of it is called the spine, and the true name is the cauda equina, where all the nerves haven't yet merged to form the actual spinal cord, which happens at your lowest rib. So from your lowest rib down, they're actually individual wires. And this is a normal disc, and here are all the nerves in that region called the cauda equina. If you have a disc problem with a tear, you actually push on these nerves, irritate them, and the irritation can cause the nerves to fail. And then that leads to, I can't feel my penis, I can't have pleasure, I can't get a good orgasm, I can't get what I want out of the sexuality. These are just pictures of patients that we've had disc bulge pushing in on the cauda equina. And then what we call annular tears, that's the inside material, that's the nucleus pulposus here, and you can see this is the disc. Here's the nucleus pulposus pushing in on the cauda equina nerves. All right, so in those men with neurologic sexual dysfunction, separate from the nerve damage of radical prostatectomy, we can do shockwave therapy. We talked about shockwave therapy to the penis. We do shockwave therapy to the back to help eliminate the nerves. And we can do spine surgery. This is someone who had nerve injury based on a cyst that was formed in the cauda equina. It's called a Tarlov cyst. If you've never seen or heard that, that's what it is. Then we're going to talk about the partner. You know, sex is not a single person show. It's a two-person show. And the comprehensive view of the data, looking at the patient and partner sexual satisfaction and how that influences people. And the conclusion is mental health, physical health, and the quality of interpersonal communication is really important predictors for the satisfaction of the patient and the partner. And we're very proud in our facility to have a sex therapist that works with us. If you're working with a urologist and they don't provide sex therapy counseling or any psychological counseling, that's not what we think to be the ideal situation. So there's all the literature that espouses why the patient and the partner needs to get involved. And I'm not going to go over each and every article. And again, if you want these articles, it'd be my honor to share them with you. At the end of the day, from the partner's perspective, prostate cancer therapy has a negative effect on sexual relationships that appear to worsen over time. And there's significant differences in the distress between the two. And when you need to get them together, you get counseling involved. And counseling is very important. I can't emphasize more. Prostatectomy is specifically associated with impaired quality of life in patients and partners. It's a dual thing, and we need to approach it where both patients and partners get treatment. And that said, it's an honor to be with my son on the Father's Day weekend and talk about all of this cool stuff about prostate cancer. I want to ask Andrew questions about testosterone and androgen deprivation and stuff, if he wants to just give another 2-minute talk on it. But we have the right to getting better in all health, and we have the right to getting better in sexual health. And it's our honor to work with you and help you achieve that. Thank you. Hi, Sandy, wherever you are, thank you for your question. Medicare covers no costs of any of my services. We're a cash-only service. Because our visits are 2 to 3 hours, and Medicare really only covers the 10-minute visit. I think you can't really do good sexual medicine in a 10-minute visit. That's just after 40 years of doing this, so I can honestly say it really does take time and energy. So we do not take Medicare for these services. Although if you joined the trials, you could get obvious, that's just joining the clinical research. So you could get Emsella treatment and or shockwave treatment without any payment. My email is in the slide set. I can give it out right now. D is in David R. Robert dot, D like dot, my name, Irwin, IRWIN, last name Goldstein, GOLDSTEIN @gmail. dr.irwingoldstein @gmail. Can Jatenzo be used in patients treated with ADH? Sure. There's no reason why not. It's the medication that is in your mouth. You swallow it. It enters your lymphatic system. It enters your bloodstream. It wouldn't be interfering with other central nervous system treatments. What are the approximate costs of your treatments? It depends what treatments you need. Shockwave therapy is $450 a treatment. Emsella is $125 a treatment. There's initial visit cost, which is $600. Those are our costs. Great presentation from Aaron Lamb. Wherever you are, Aaron, thank you. So much information. Well, there's a lot of stuff going on, and I think I've only given you 10%. Some of those charts showed improved quality of life after ADT ends, and testosterone treatment returns. Should be very encouraging to those facing their fears when starting androgen deprivation treatment. The answer is true. We reverse the issues of androgen deprivation. But I want to be careful here. I'm trying to make it evident that testosterone treatment in men with prostate cancer isn't for every patient with prostate cancer. If you have high risk prostate cancer, if your PSA is elevated, if you have metastatic disease, testosterone therapy is probably not a smart idea. But there are a ton of patients who have testosterone low values and symptoms that are affecting their life quality, whose PSA is low, who would benefit greatly from treatment based on all the data that we're finding. So I want to emphasize that. I think those are all the questions.